So the adrenal glands are located directly over each kidney and are composed of two parts, an outer portion called the cortex, which secretes a number of hormones that are essential for life, and an inner portion called the medulla, which secretes epinephrine and norepinephrine is considered part of the sympathetic nervous system. So we're looking now at corticosteroids and steroids. They are activated by ACTH from the pituitary gland, essential for life functions. They regulate water and salt, regulate carbohydrate metabolism, produce anti-inflammatory effects. And the adrenocorticosteroids, or the corticosteroids, and the steroids all refer to the same substance. Mineral corticosteroids, or glycocorticoids, are both secreted by the adrenal cortex. How is the ACTH regulated in the body? You got it again, the hypothalamus. So adrenal cortex hormones, the glycocorticoids, regulate metabolism of proteins and carbohydrates, reduce inflammatory and immune system responses in many conditions. Some examples you see here: arthritis, allergic disorders, asthma, cancer. Excessive doses, long-term therapy, can lead to the Cushing's disease, or what we call the Cushingoid symptoms of Cushing disease. Here you see those symptoms: fatigue, weakness, edema, potbelly, buffalo hump, excessive hair growth, mood and personality changes, and psychological dependence. Mineralocorticoids regulate blood levels of sodium and potassium. They are the most important mineralocorticoid is the aldosterone, and this acts on the kidney to promote retention of sodium and water and excretion of potassium and hydrogen. So let's talk about some administration techniques with steroid therapy. Steroid therapy can be administered orally, parenterally, topically, by inhalation, or by local injection. They're usually given in two different ways. There's an alternative day therapy where they're given every other day in the morning, and then there's a declining dosage. And this therapy gives a therapeutic dose and then it tapers it off. So it's a dose pack. So the main role of insulin and glucagon is to regulate the metabolism of proteins, fats, and especially carbohydrates. And the insulin is produced in the islets of Langerhans. And so here we're looking at pancreatic hormones, and we have the diagram of the pancreas here. So let's look at some drugs used as anti-diabetic agents. Insulin, I think most of us know a little bit about insulin and know that it aids in diabetes. So it aids in utilizing glucose as energy, stores excess glucose as glucagon in the liver, and it converts glucose to fat. It also decreases blood glucose levels. Diabetes mellitus. So this is a disorder of carbohydrate metabolism. There's an insulin deficiency and also an insulin resistance. So the classic signs we see is the polydipsia, polyphagia, and polyuria. And the 6 leading causes of death in the United States. So that's pretty big. It's 6th leading cause of death in the United States. It affects about 16 million Americans. So chances are you know somebody who is affected by this. And 90 to 95% of cases are adult onset. So we see this coming on in adulthood. Type 2 diabetes is now growing health concern for U.S. children and teens. And most authorities believe that diabetes mellitus may be caused by any abnormal level of pancreatic function. So again, we see this in 90 to 95% of cases are adult onset, but we are seeing some increases in non-adult onset there. So let's look at type 1 insulin dependent diabetes mellitus. So that's T1DM, or formally abbreviated IDDM. In this case, patients have little or no endogenous insulin, and they require exogenous insulin to survive. And this is likely due to a genetic abnormality. And type 2, which is non-insulin dependent diabetes, we usually see this as a mature onset, patients having some insulin function with low production or insufficient secretion of beta cells. And this can be a result of the aging process or poor diet or genetic factors in type 2. So let's talk a little bit about treatment. Dietary adjustments to limit carbohydrates, consistent exercise, drug control, insulin, oral hypoglycemics, drug affecting glucose absorption or production, sometimes where they're prescribed in this case. And this is really important in terms of the patient education because it makes it more difficult. We're talking to this patient about dietary adjustments. We're talking to them about needing to have consistent exercise. Again, stressing the importance of how much the drug control is needed. So that is a really big part in the patient education, is helping them to understand, but also helping them to feel supported. And you're taking a lot away from them when they are diagnosed with diabetes, and there's some pretty major changes that have to happen. Do you have an example from your own personal or other experiences that you've seen somebody who had been diagnosed and kind of the things that they went through? I do personally. My dear niece, she's only 13. Well, now she's actually 15, but she was only 13 when she was diagnosed, and she got very, very sick and didn't have energy and was just sleeping constantly for days, and was drinking water like crazy. And so finally her parents took her in, and it was really hard for all of them to accept that, because for 13 years she had been fine and they had no idea, and she was diagnosed with diabetes. And trying to help a 13-year-old, now 15-year-old, make sure that they change their diet, make sure that they exercise. Really, the drug control was a huge issue because she's at school, and you have to do the blood tests and then figure out how much insulin that you need to give. So in my own personal life, I have definitely seen this come into play, and it's not an easy one. So again, patient education and helping them feel supported is key. So hypoglycemia versus hypoglycemia. So we have hyper and hypo. There's those words again. They have been one of our key terms that we've had in ALH4. And this table 27 demonstrates the difference between the hypoglycemia and the hyperglycemia. So please make sure that you take a moment to look at this in your book and to really understand the differences there. So administration of insulin in type 1 diabetes, it does require a subcutaneous injection. So we haven't done all of our lessons on injections. That will be next semester. But subcutaneous is into the subcutaneous area of the skin. And gastric juices destroy insulin. Previously, only pork and beef insulin were available. Today, insulin is synthesized by a recombinant DNA technology, and it continues to grow and change with time and with science. And insulin preparations vary in time of onset of action, time of its peak action, and the duration. So it's important that depending on what drug, what insulin that the patient is taking, they need to know how to prepare it, what amount of time of onset and action, and when is it going to peak, and how long is it going to last. So see Table 28 also to look at what types of insulin preparations are available and how they compare in terms of onset and action. Here is a table. We're looking at actually figure 26. How would this graph be helpful to a physician in determining the type of insulin to use in patient therapy? I'm going to let you look at that for a minute. It assists with understanding how the types of insulin interact throughout the day, and that can then help the physician know what type is best for his patient. So we're still looking at administration of insulin in type 1. Regular insulin is always clear. Other insulins are cloudy because there are added precipitates in there. Return of the precipitates to solution by rolling vials or pens between hands. So if you're taking the vial, or if you're using a pen, depending, and you roll it between your hands, this can return it to the solution, and that way you're getting an even solution. You never want to shake or agitate the insulin, and store pre-filled syringes vertically to prevent clogging of needle, because again, if the precipitate is there and it's blocking the needle, then you're not going to be able to administer correctly. So let's talk about the insulin delivery system. What are the guidelines that relate to the mixing of different insulin preparations? You're going to want to look in your textbook and kind of understand that. So traditional delivery systems or insulin delivery systems are usually syringe and needle. We now have pens. We have jet injectors that spray the insulin through the skin without a needle. That's pretty cool. I never thought we would see that. Portable insulin pumps, so people can actually wear the pumps and have them kind of hidden underneath their clothing. Implantable pumps that are implanted. Inhalation, so they're using nasal inhalation or they're breathing it in, and also they do have transdermal patches. Here in box 220, we're looking at insulin and other drugs. Again, I know you can't see it that well on the screen. Maybe you can, I don't know. It's probably about the same size or bigger, but I just want you to make sure that you take the time to look at box 22, the drugs that interact with oral anti-diabetic agents. It's important to note this. Although usually well tolerated, some people will have allergic reactions, and they should watch for disappearance of fat at the injection site when the site is not rotated, blurred vision, and hypoglycemia. So drugs used as oral anti-diabetic agents, families of oral hypoglycemic agents. We have a list here. So it's important to note that sulfonylureas should only be used if they've tried a change in diet and exercise and that hasn't been effective in controlling the elevated blood sugar levels. Sulfonylureas can produce more severe effects in elderly or debilitated or malnourished patients. Because they vary in onset and duration, the patient must adhere to a strict diet time and well-balanced meals for them to work. And some researchers have now linked these medications to an increased risk of death from cardiovascular disease. So it's important to note those side effects. So glucose